Hello everyone. In this class, we'll try to learn about pathophysiology of shock. The learning objectives of this class would be define and classify shock and give example for each type of shock. List compensatory mechanism activated by hypovolemic shock. Appreciate the physiological changes of compensatory reactions in hemorrhagic shock. Understand the mechanism of refractory shock. Briefly describe the other types of shock and appreciate the physiological basis of treatment of shock. Shock is a syndrome in which there is inadequate tissue perfusion associated with a relative or absolute decrease in cardiac output. There are different types of shock. Hypovolemic shock. Inadequate cardiac output is due to the decreased volume of fluid in the vascular system that leads to hypovolemic shock. This occurs due to the acute hemorrhage, which is called as hemorrhagic shock, because of the injury, which is called as traumatic shock, can occur during surgery because of the blood loss, which is called as surgical shock. It occurs after the burn because of the loss of extracellular fluid, which is called as burn shock, and can occur in metabolic diseases like adrenal insufficiency, diabetic ketoacidosis, etc., and in severe diarrhea or vomiting. Distributive shock. The blood volume is normal, but the blood pressure decreases due to a sudden increase in capacity of the vascular compartment, and that occurs due to the acute marked vasodilatation. This may be of the following type. It can be neurogenic shock, anaphylactic shock, septic shock. Neurogenic shock, as it is seen in case of fainting. Anaphylactic shock, it is due to the acute systemic allergy or anaphylaxis. Septic shock occurs following septicemia, and endotoxic shock occurs due to the infection of gram-negative bacteria. Cardiogenic shock, where cardiac output decreases due to the decreased ability of the heart to pump the blood. It is seen in acute myocardial infarction, heart failure, and cardiac arrhythmias. Obstructive shock, where cardiac output is decreased because of the obstruction of the ejection of blood from the ventricles. It is seen in cardiac tamponade, constrictive pericarditis, cardiac tumor, and tension pneumothorax. Coming to hypovolemic shock, it is the commonest of all shocks. Common forms of hypovolemic shock are hemorrhagic, traumatic, surgical, and burn shocks. Hemorrhagic shock. Acute hemorrhage more than 15 ml per kg body weight loss is going to result in shock. Some of the features of hypovolemic shock are hypotension, tachycardia, rapid and thready pulse, cold and pale skin, tachypnea, intense thirst, restlessness, and usually patient is uh, conscious. There are different stages there are two stages, that is reversible and irreversible stage. In reversible stage, there will be activation of the compensatory mechanism. Patient condition improves. The compensatory reactions are divided into short-term and long-term mechanisms. Rapid compensatory mechanisms. The rapid compensatory mechanisms are primarily neural and vascular. Though the hormonal mechanisms also play a role. Rapid compensatory mechanisms are mostly due to the stimulation of sympathetic system. Sympathetic activation occurs mainly due to the decreased stimulation of baroreceptor and hypoxia. But in severe shock, chemoreflex and Cushing's reflex are also activated. Neurohormonal mechanisms. Tachycardia. Decreased blood pressure decreases stimulation of the baroreceptors, which results in sympathetic activation that increases the heart rate. There will be vasoconstriction. This occurs due to the decreased stimulation of baroreceptor that activates sympathetic system. Vasoconstriction occurs almost in all parts of the body except in cerebral and coronary arteries. There will also be cutaneous vasoconstriction. Skin becomes pale. Therefore, the acute hemorrhagic shock is also called as cold shock. There will be renal vasoconstriction, which decreases the renal blood flow and GFR. But efferent arterioles are constricted more than the afferent arterioles. Urine formation is grossly reduced. The nitrogenous waste products are retained in the body in prolonged shock that results in uremia or azotemia. Venous return increases due to the vasoconstriction, which occurs due to sympathetic stimulation. There will be increased thoracic pumping uh, that occurs because of the hyperventilation, which increases the thoracic pump and contributes to increased venous return. There will be increased skeletal muscle pumping, that is, active movements of the body parts increases the skeletal muscle activity, that in turn increases skeletal muscle pumping, which contributes to increased venous return. There will be capillary fluid shift, that is, shift of the blood from interstitial fluid compartment into capillaries. In hemorrhagic shock due to acute blood loss, the hydrostatic pressure inside the vessel decreases. This reverses the net filtration pressure gradient, and fluid from the interstitial tissue space enters into capillaries. This also contributes to increase in blood volume that increases venous return. There will be activation of chemoreceptor reflex. Severe blood loss causes hypoxia, stimulates chemoreceptors, resulting in venoconstriction, and stimulates the respiratory center that causes hyperventilation. Activation of Cushing reflex. Cerebral hypoxia directly stimulates the vasomotor center, causing vasoconstriction, and tries to maintain blood pressure and flow to the vital organs of the body. Increased secretion of catecholamines. Hemorrhage stimulates secretion of catecholamines from adrenal medulla. This occurs due to the sympathetic stimulation. Increased catecholamines stimulate heart to maintain cardiac output and also cause vasoconstriction, which maintains the blood pressure. Catecholamines also stimulate the reticular activating system, for which the patient is often conscious and restless. There will be increased secretion of vasopressin. Decreased blood volume stimulates secretion of ADH from the posterior pituitary. ADH increases water reabsorption from kidney and restores blood volume. In higher concentration, it also causes vasoconstriction that restores blood pressure. Increased secretion of cortisol. Glucocorticoid secretion increases due to the increased ACTH secretion. Glucocorticoid plays a crucial role by increasing the responsiveness of blood vessels to catecholamines through its permissive and vasoreactivity effects. There will be activation of renin-angiotensin system. Hypovolemia and sympathetic stimulation increase the secretion of renin from JJ cells of the kidney. Renin converts angiotensinogen to angiotensin 1, which is further converted into angiotensin 2 by the action of angiotensin converting enzyme. Angiotensin 2 restores blood volume and blood pressure by the following actions. By its peripheral action, where it is a potent vasoconstrictor, it increases the blood pressure. It increases aldosterone secretion from the adrenal cortex. Aldosterone increases water reabsorption from the kidney. It directly increases sodium and water reabsorption from kidney by acting on the proximal converted tubule. It increases the release of norepinephrine from sympathetic nerve endings. Its central actions are it stimulates dysbiogenesis, that is, increases drinking by stimulating thirst centers. It stimulates vasomotor center and increases blood pressure. It increases ADH secretion. It also increases ACTH secretion. There is also increased aldosterone secretion. Aldosterone secretion from the adrenal cortex increases due to the action of angiotensin 2, ACTH, and hypovolemia. Aldosterone increases water and sodium reabsorption from collecting duct and the distal converted tubule of the kidney. So these are the short-term mechanisms. Coming to the long-term compensatory mechanism, there will be increase in the synthesis of erythropoietin within 48 hours, and that increases the red cell production, that is red cell count, and returns to normal within 2 to 6 weeks. Increased plasma protein synthesis that occurs within 2 to 4 days. It increases the hemoglobin synthesis and therefore the RBC production. Increased plasma protein also restores the oncotic pressure of the plasma. In irreversible stage, the compensatory mechanism failed to improve body functions. Cardiac output and blood pressure decrease despite normal blood volume. This is also called as a refractory shock or irreversible shock. Usually patients die irrespective of judicious treatment to increase the circulatory status. The mechanisms of refractory shock. Initially, precapillary sphincter constrict causes hypoxic tissue damage. The free oxygen radicals, which are increased from the damaged tissue uh, and granulocytes, facilitate the further vessel damage. Later, in advanced refractory shock, precapillary sphincter dilate, but the venules constrict, which increases transduction of fluid into the interstitial space, increasing the blood volume further. The hypoxic damage to the GI tract allows the entry of bacteria into circulation, resulting in bacteremia and septicemia. The release of endotoxin from bacteria and toxic materials from septic tissues inhibit cardiorespiratory center. Cerebral hypoxia depresses medullary cardiorespiratory centers, which further decreases blood pressure and heart functions. Due to hypotension and tachycardia, coronary blood flow decreases. This further decreases myocardial function. Damaged blood vessels and damaged tissue release various coagulants that trigger disseminated intravascular coagulation, and this results in microembolism. Pulmonary microembolism finally lead to acute respiratory distress syndrome, that is also called as shock lung. Other hypovolemic shock, traumatic shock. This occurs due to the severe injury, especially when muscles and bones are extensively damaged. Mechanism. Different mechanisms are bleeding when it occurs into the injured muscles, that is internal bleeding, which will be responsible for the cause of shock. Rhabdomyolysis, that is breakdown of the skeletal muscles due to the muscle crushing, is another cause of a shock. Myoglobin released from the damaged muscles block the renal tubules and causes acute renal failure. In reperfused areas, the increased accumulation of the calcium also causes tissue damage. Surgical shock, seen in surgical procedure with improper hemostasis or prolonged surgeries. Burn shock occurs in burns where plasma is lost from the burnt surface as an exudate. The exudate is rich in plasma proteins and fluid and does not contain red cell. This results in hemoconcentration. Therefore, hematocrit is high in burn shock. Infection leading to septic shock complicates the hypovolemic shock in burn. Hemolytic anemia also complicates the condition in burn. This is in brief about the different types of shock. Thank you.